If topical minoxidil did nothing for you, your follicles may not be resistant to the drug. They may simply have failed to switch it on. Topical and oral minoxidil contain the same active ingredient, but they take very different routes to the follicle. Controlled trials show similar average results. In real life, however, oral minoxidil may work better for some patients because its delivery pathway can be more dependable. Minoxidil is generally considered a prodrug in hair growth treatment. It must be converted into minoxidil sulfate, its more active form. That conversion is performed by enzymes called sulfotransferases. SULT1A1 is the best known, but it is not acting alone. Multiple human sulfotransferase activities may contribute to minoxidil activation. Think of them as chemical switches. Most people have the relevant genes. What varies is enzyme activity. So two people using the same 5% solution may produce very different amounts of active minoxidil sulfate. For topical minoxidil, that creates an obstacle course. You must apply it to the scalp, not the hair. It must cross the skin barrier, reach the follicular cells, and then be activated locally. Poor application, limited penetration, irritation, or low follicular SULT activity can weaken the result. At least 90% of an oral dose is absorbed through the gastrointestinal tract. It enters the circulation and passes through the liver, where sulfotransferase enzymes may help produce active minoxidil sulfate before it reaches the follicles. Oral minoxidil does not completely bypass activation, and it does not make follicular biology irrelevant. It changes where activation and delivery can occur. Topical treatment depends heavily on correct daily application, skin penetration, and local activation. Oral treatment is less dependent on those checkpoints. It also avoids residue, styling problems, and contact irritation that can undermine long-term adherence. In simple terms, topical minoxidil asks the scalp to complete almost every step correctly. Oral minoxidil distributes more of that work across the gut, liver, circulation, and follicle. A small 2024 study followed 41 patients with androgenetic alopecia who took low-dose oral minoxidil for 6 months. About 63% improved. Surprisingly, patients with low follicular SULT1A1 activity had an 85% response rate compared with about 43% among those with high activity. The study was small and does not prove the mechanism, but it supports an important possibility. Low SULT1A1 activity in the follicle may predict a poor topical response without predicting a poor oral response. A topical non-responder may not be resistant to minoxidil itself. The problem may be the topical delivery pathway. Oral minoxidil may work better for patients with poor topical absorption, low local activation, scalp irritation, diffuse thinning, or inconsistent application. The molecule is not stronger. The route simply has fewer delivery bottlenecks. But systemic delivery also means systemic side effects. Unwanted facial or body hair is common. Headache, ankle swelling, dizziness, palpitations, and blood pressure changes may also occur. The 5 mg dose used in that trial is not the correct dose for everyone. Oral minoxidil is used off-label for hair loss, so it should not be treated like a supplement. Blood pressure, cardiovascular history, swelling, kidney problems, and current medications should be reviewed before starting it. And remember, minoxidil supports hair growth, but it does not directly block DHT, the main driver of androgenetic alopecia. Some patients still need separate treatment for the underlying process. The final answer is simple. Topical minoxidil asks your scalp to deliver and activate the drug correctly every day. Oral minoxidil uses gastrointestinal absorption, liver metabolism, and systemic circulation to create a more consistent route to the follicles. And for some patients, that more reliable route can make all the difference.